Warm welcome to all of you joining us from across India and around the world for today's webinar, Maternal Health in a Changing Climate, Strengthening Health Systems. My name is Swati Bakshi and I serve as the Deputy Director at the Harvard Chan School of Public Health, India Research Center. It's a pleasure to welcome you all today. The Harvard Chan India Research Center was established in 2015 as the first global footprint of the school and is led by Dr. K. Vishwanath, the Lee Kumke Professor of Health Communication at the Harvard Chan School of Public Health. The center works to advance public health in India through three strategic goals: research, training and capacity building, and knowledge translation and communication. Over the years, we've worked closely with researchers, policymakers, practitioners, and communities to bring together diverse perspectives and generate evidence around some of the most pressing public health challenges facing India today. Now, let me take a moment to briefly set the context for today's discussion. Climate change is increasingly emerging as a major public health challenge with disproportionate impacts on vulnerable populations, including pregnant women and newborns. Pregnancy, as we know, is a critical phase in a woman's life, marked by profound physiological, metabolic, and psychological changes, which can increase vulnerability to heat stress, poor air quality, infectious diseases, food and water insecurity, and other climate-related risks. At the same time, these risks are often compounded by existing social and economic inequities, making maternal health an urgent priority for climate-responsive public health action and stronger health systems. So, to help advance these conversations, our center launched the webinar series, Climate Change and Health, Science, Policy, and Public Health in Action, which brings together global and national experts to share evidence, identify emerging gaps, and discuss actionable strategies to strengthen India's public health response to climate change. Today's webinar, the third in the series, focuses specifically on the intersection of climate change and maternal health in India, and on how health systems can better prepare to respond to this growing public health challenge. We are very fortunate to be joined by an outstanding panel of experts today, and it is my privilege to introduce them. First, we are delighted to welcome Dr. Caleb Dresser. He serves as an assistant professor of emergency medicine at Harvard Medical School and assistant professor in environmental health at the Harvard Chan School of Public Health, where he leads work on healthcare-related solutions at the Harvard Chan Center for Climate, Health, and the Global Environment. Welcome, Dr. Dresser. We are pleased to have you with us today.
Thank you.
Next, we are joined by Ms. Mirai Chatterjee. She is a leader of the Self-Employed Women's Association called SEWA, a national union that has organized about 3.8 million informal women workers in India, obtain work and income security, food security, and social security. She is the director of SEWA's social security team, including healthcare, childcare, and insurance. Welcome, Ms. Chatterjee. It's a privilege to have you with us. And finally, Dr. Srivatsan Raghavan. He is a research scientist trained in clinical and environmental epidemiology at the Translational Health Science and Technology Institute and program manager of Heat in Pregnancy, India Study, a Wellcome Trust-funded multi-site study examining the effects of extreme heat on maternal, placental, and fetal physiology, lactation, and newborn health. Welcome, Dr. Raghavan. It's wonderful to have you with us today.
Thank you.
I must say these brief introductions hardly capture the remarkable depth of expertise and experience our panelists bring to today's discussion, and we are very much looking forward to an engaging and insightful conversation. This session will be moderated by Dr. Shruti Mahalingaya. She's a Mark and Catherine Winkler Associate Professor of Environmental, Reproductive, and Women's Health at the Harvard Chan School of Public Health, and she also serves clinically as a physician at Massachusetts General Hospital specializing in ovulation disorders, reproductive endocrinology, and infertility. Thank you, Dr. Shruti, for joining us and for moderating today's discussion. Before we begin, a quick overview of the session flow for today. We'll begin with a 50-minute panel discussion, followed by 15 minutes of audience question and answers before we conclude the session. We encourage all attendees to please share their questions through the Zoom Q&A box, and our team will bring as many of them as possible into the discussion. With that, I'll now hand it over to Dr. Shruti to begin the discussion. Over to you, Dr. Shruti.
Thank you so much, Dr. Bakshi. And I just wanted to again express gratitude to the India Research Center for covering these important critical issues, as well as to thank our panelists today for sharing in advance your insights from your lived experience and research. With that, I would like to open up first with a question to Ms. Mirai. Ms. Mirai, could you please help us understand what are the major climate-related risk factors affecting women's occupational health in India, particularly among informal workers, including pregnant women?
Thank you very much, Dr. Shruti, and I'm delighted to be here. And I thank all of you and my co-panelists, and also I'm happy to be at my alma mater, online, of course. Coming right to the issue at hand, I thought it might be good to remind ourselves of the size and nature of the informal economy in India, but also worldwide. The ILO estimates about 61% of the world's workers are in the informal economy, which is about 2 billion workers. And if I speak about India, it's 93%. It's almost everybody, upwards of 500 million workers. And of course, many of them are women. And as was mentioned earlier by Swati, these are often called unprotected labor, and they are or vulnerable groups. They are characterized by no work or income security and very little social protection and financial protection. Coming to women informal workers, I must say that generally our sisters in SEWA, we see that they get the worst work. They get the most hazardous work that men will not do. And I'd like to share a couple of the issues that we have studied. We have been engaged in a study with the National Institute of Occupational Health, which is a center of the Indian Council of Medical Research, and in collaboration with WIGO, which is the Women in Informal Employment Globalizing and Organizing, a mouthful, but an expert in informal economy worldwide. So what we found working with women farmers, street vendors, home-based workers who are women who produce goods and services from the home, and construction workers are the following. What's common are musculoskeletal issues, back pain, shoulder pain, pain in the limbs, eye issues, dermatological issues, rashes, and so on. Coming to heat, we found that the average exposure is 6 to 7 hours per day. Because I'm going to focus on heat because we're in the middle of a heat wave, quite frankly, here in Ahmedabad with 45 degrees Celsius temperature. So exposure is 6 to 7 hours per day, and of course longer. And of course, there's no shade, no time off, no rest, no cooling spaces. Some of the informal workers are quite innovative and find low-cost solutions like our street vendor sisters, buy big umbrellas and so on. But our study found that about 33% of urban workers and about 40% of our rural sisters complained of high blood pressure, dizziness, nosebleeds, dehydration, nausea, fatigue, stress, anxiety, and of course, heat stroke. And many of them are anemic. Importantly, 65% of them in our small pilot study urban workers reported income losses, and their average income is about 3,000 rupees a month, roughly $300. And so therefore illness and this heat, extreme heat, they're unable to work. I think to make it alive from one of our studies, I'd like to just quote from one of my SEWA sisters, who's a garment worker, who works in a tiny 10 by 15 home, Rehat Ben. She says, our homes are small, we feel dizziness, we feel so hot, fans don't help, and our productivity goes down, we lose income. Another study that was done in collaboration with us at SEWA by the M.S. Swaminathan Research Foundation found that heat-related illnesses were significantly higher in informal workers, about 83%, as opposed to the formal workforce, 67%. Coming to mental health, and I'll come to pregnant women in a minute, we find in our study much more stress, anxiety, on a whole host of issues. But I must say, primarily loss of work and income due to climate related risk factors. We're talking about heat, but also flood, cyclone. We live in a cyclone prone area as well. Crop failure, unseasonable rain that destroys the crop. And also balancing both paid and unpaid work responsibilities, household responsibilities. One of the things that's rarely mentioned, and this came out very strongly during COVID, but even now, is the absence of childcare. For informal women workers, this is critical. And when SEWA has formed creches and cooperatives for childcare, we found women reported peace of mind, much less stress. The earlier study I mentioned of the MS Swaminathan Foundation also found greater physical and sexual violence on women, particularly in heat stress areas, high heat index areas. And obviously, all of this is compounded by the living and working conditions of informal workers, who in India constitute the working poor. And of course, they're from the poorest castes, communities, religious minorities. Coming to pregnant women, one of the things that I really feel really strongly about is the lack of maternity benefits, no maternity leave. For the formal sector in India, we have 6 months of leave. But for our sisters in the informal economy, there's nothing. As one of our sisters in our study said, who's a street vendor, I'm 5 months pregnant, but I continue to sell vegetables even in the hot summer months. I have to earn for my family. And one of the construction workers, Kamla Ben, said, we work right up to the 9th month. Our contractor never pays us a single rupee when we are off work. We get no maternity benefits. So, obviously this has a huge impact on their well-being. And again, the study that I referred to by the Swaminathan Foundation, they found that women in very high heat vulnerability districts were about 0.5 percentage points more likely to report miscarriage or stillbirth compared to other districts. Of course, our study is still in progress, so I can't tell you immediately of the SEWA study. And the other thing that they found is that there's a link between high ambient temperatures to interference with placental development, uterine contractions, systemic inflammation, and of course, the increase of miscarriage risk. They also surveyed women and they found 15% of the women reported preterm deliveries. They did a study across 7 states, which we were involved with, and 12% delayed labor, 20% cesarean sections following high heat exposure. And of course, maternal anemia was higher in these high heat vulnerable districts, 59% compared to 49% in low vulnerability areas. And of course, I don't need to tell this audience and to you, Shruti, that, in any case, Indian women who, hardly put on weight, frankly, no question of putting on 10 to 15 kilos. So yeah, one other point quickly is the access to care. What happens is when there's heat or a cyclone or, floods or unseasonable storms, is that their access to care gets immediately affected because caregivers are not able to reach them. They are not able to reach referral services. And we have also got reports of this in our studies, that access to care in extreme heat conditions goes down quite dramatically. So I think we have robust evidence, both anecdotal and research evidence and testimonies of the increased risk on pregnant women from extreme heat, as I said, and of course amplified by their living and working conditions, which are in extreme vulnerability. I think I'll stop there. Thank you.
Thank you so much, Ms. Mirai. My reflection hearing the adversity, these women, some pregnant, are undergoing is that this extreme adversity, even without the heat and climate related factors, already puts a potential limitation even on contemplating conception or achieving pregnancy. And so I think these points are really, really important. And thank you for creating the context here of what the kind of informal economy faces. My next question was for Dr. Shri. Given your background and research in kind of the biology and epidemiology, I wanted to open up by asking you about your cohort, the Garvini cohort, which has generated longitudinal evidence on pregnancy outcomes in India. And if you could just share a little bit about what this cohort has added to our understanding of how climate change affects maternal and perinatal health, and how can evidence from this cohort inform national guidelines or maternal health programs in India?
Hi, thank you, Dr. Shruti. It's truly an honor being here. So I think Dr. Mirai has quite nicely summarized the context here. And India is almost bearing 20% of the maternal and child health morbidity load. It contributes a huge margin disproportionately to preterm birth load as well. And as we all are aware, preterm birth is primarily multifactorial, and it requires a multi-pronged approach. So I think to tackle that, the team at THSTI led by Professor Shivani Bhatnagar, Professor Nitya Abba, uh, they launched this program funded by the Department of Biotechnology called Garbini. It's an interdisciplinary group to study adverse birth outcomes, and it was primarily focused on preterm birth. It involves, so it started in 2015. Now, recently, the Honorable Minister, Dr. Chatterjee Singh, had celebrated 10 years of Garbini, where we've been able to recruit about 12,000 women longitudinally. They are enrolled less than 20 weeks of gestation, and then they are followed up. And during the course of time, their clinical data, biological specimens for omics analysis, which includes genomics, proteomics, metabolomics, and microbiome, along with serial ultrasound data, is taken along. And then these women now have been, sort of like transferred. The babies of them have now led to a birth cohort where we have prenatal, antenatal, and postnatal changes to see how it affects things in the long run. One of the determinants or risk factors that we are studying, which I happen to work on, is the environmental one, and more specifically air pollution and heat. Um, so I think and it's one of Southeast Asia's largest cohorts. We have lakhs of aliquoted specimens, over 30,000 videos of ultrasounds, and a really rich and well phenotyped data set. Um, this sort of allows us to draw slightly better inferences than looking at live birth registries, because it also helps us, because we know preterm birth as well as pregnancy outcomes during the course at the end, also at the end of course of pregnancy, are not they are multifactorial, and they have several positive pathways. So it allows us to holistically look at the complete picture. An extension of that is the Heat and Pregnancy program, where we are now trying to look at three areas apart from Gurugram, where Garbini is centered in, which is in the National Capital Region of India. It bears a decent amount of heat load, but also air pollution. I think Delhi is notoriously famous for air pollution load as well, and the National Capital Region. Similarly, we have a site called in Bilaspur, Chhattisgarh, as well as in Pondicherry. So it gives us very three distinct climatological zones where we'll be enrolling these women. And we are trying to overcome conventional environmental epi studies where they use satellite-based measurements to sort of quantify the exposure. And we are trying to do personalized exposure assessments as well on these women, both working as well as at home. It sort of gives us a better idea of their physiological responses, as well as their indoor environment. This is also supplemented by a very in-depth qualitative vertical that we have that looks into their lived experiences, something similar to what Dr. Mirai has mentioned, but through in-depth interview. So we are trying to, cover both the quantitative side as well as the qualitative side to help. So the leads that we get from both, like Garbini itself will generate, leads for vulnerable windows, temperature thresholds, which we will prospectively validate in these three sites separately, and then that complements very well with what we're trying to understand through lived experiences and these qualitative experiences that these women face. Many, I think, I would be repeating what Dr. Mirai has already mentioned. So and these, once you know these leads and these thresholds, it also helps us to frame policy around them, and to, so for example, I'll give a very short, it's that for preterm birth, and if I look at three outcomes primarily, preterm birth, stillbirth, and small for gestational age, and which Lancet, the people have now clubbed together as small vulnerable newborns. If, that's a public health framework that people have recently introduced. 50% almost in the papers published from the Garbini group, almost 48% of the women born from the Garbini mothers were small vulnerable newborns. That's a huge number. And if you add the stress of heat or air pollution or climate change, it's not, it compounds to the problem. Additionally, I'll just quickly add on to what Dr. Mirai has already said, that we're aware that the body is already under, a huge physiological load during pregnancy in terms of hemodynamics, water balance, inflammation, placental development, as well as, nutrition, providing adequate nutrition to the mother and the child. So, heat and air pollution ends up, climate change in essence complicates that, right? Because the body is trying to cool itself, so it will try to redirect the blood to the peripheral area, but it also needs to send blood to the placenta. So it's a very unique and distinct challenge. Garbini and programs like Garbini allow us to study that because we have USG data, where ultrasound data that allows us to study the blood flow, what's the placental location. So this overall gives us a wonderful opportunity to find targeted windows or vulnerable windows. For example, the preliminary work that we have done, we noticed there are very distinct vulnerable windows and threshold patterns for preterm birth, for stillbirth, and small for gestational age. And thus they require targeted antenatal screening and antenatal interventions. Simple thing can be targeted hydration plan. It's very simple, it's very scalable, but cohorts like this help to plan interventions in that regard.
Thank you so much, Dr. Shri. It's what a amazing insight with this population to contribute to, as you said, understanding the vulnerable time windows and setting kind of targeted screening and intervention. And we'll get back to that maybe in just a moment. I'd love to hear, Dr. Caleb, about your kind of insights from not only your patient care, but your research, since your work examines what climate change means for healthcare systems, responding to the crisis and the patients that they serve. So in the context of women's and maternal health, from all of your experience and work, what do you think healthcare systems and frontline providers should prioritize in terms of preparedness, service delivery, and risk communication for pregnant women? And also, if you could comment about how that access can be, the barriers can be overcome for people who can't necessarily come in to a hospital.
Yeah, great question, and thank you. I look at this as two related but somewhat distinct issues. The first is what we've been talking about so far today, which is how do we understand and address the impact of climate-related hazards, things like increasing exposure to dangerous heat, increasing exposure to dangerous flooding, increasing episodes of short or long-term displacement, and all of the health impacts that those can have. There's a second category as well, though, which is in a changing climate, is our healthcare system able to provide the basic healthcare it needs to be providing? And this is obviously, even if we remove climate change from the equation, a huge challenge throughout much of the world and certainly in many parts of India. And so these are two parallel challenges we have to deal with. I want to speak a little bit about the second category. My colleagues have eloquently addressed the first. When we look at the healthcare system and what particularly women of childbearing age who are going through pregnancy, are delivering babies, are trying to raise healthy children need. They need stable access to healthcare facilities. They need to be able to deliver in safe, clean, hygienic settings. They need access to surgical obstetrical services in emergencies. And this has to be available in a setting that is physically accessible within whatever the local transportation systems are. And so if we think about what climate change means for reproductive health care, pregnancy, and childbearing in India, there's this long list of population level threats, physiologic impacts from heat, impacts from infectious disease, nutritional impacts, all of which will be stressing this population. And at the same time, the healthcare system needs to remain online. If there is a cyclone, does the local hospital that has the one operating room with a trained obstetrician, does that hospital have power 2 days after the cyclone? Does it have backup power? If it doesn't, where are people going to go? So those are really important questions, and I think we have to address this through parallel channels. Within the healthcare system, some of this falls under good disaster preparedness, disaster planning work. Some of this can be solved with or prepared for, mitigated with good engineering, right? On-site solar installations with backup batteries are going to increase local resilience to power failures, are going to provide perhaps cooling during really hot weather. At the same time, we also need staff that understand the risks and are able to provide care that is climate informed. If you are 36 weeks pregnant, and we know that in South Asia, higher temperatures are associated with preterm birth, is your doctor or nurse telling you that? And if they are, is that information actionable for you in your life? And this is where there is a limit to what we can solve within healthcare, right? Even a well-educated set of healthcare providers providing good information to patients can only go so far if the social circumstances of people's lives mean that that information is not something they can act on, even if they would like to do so. So this is an interrelated, complicated problem. How do we address this? What is the path forward? Well, I think we have to work in parallel. Understanding social concepts, as Mirai was addressing, is really, really important and has to be paired with a lot of this conversation. Understanding the physiology and what are the actual evidence-based recommendations we can provide is still an emerging area, right? We've done a much better job as a society of understanding that we have a problem than thus far developing and testing and quantifying the utility of interventions to address this. So we need to keep doing that research, as Sri was talking about. And then I think we also need to be innovating within healthcare to meet people where they are within the social fabric of our existing societies to meet these needs. So one example of that that I've been involved with over the last few years is the Harvard AmeriCare's Climate Resilience for Frontline Clinics Toolkit. This came out of work in the United States, but at this point has also been adapted in collaboration with the Department of Health of the Philippines for use in the Philippines and has been deployed nationally by the government of the Philippines. And this is providing resources that include patient education materials so that if a doctor or nurse is meeting with a pregnant woman and wants to provide counseling about heat or counseling about readiness for an upcoming cyclone, they have a worksheet with fill in the blank areas where they can say, here's what your plan is going to be. This is intended to make this easy to understand and actionable. It includes educational resources for those clinicians, most of whom did not learn about climate hazards in medical school or nursing school. And it includes information for administrators. How do you keep the lights on in a primary care clinic? How do you re-enter a clinic safely after a flood has maybe damaged the buildings? What are the things you need to be thinking about? So trying to make practical, accessible information available. And then in the Philippines, we met with a large number of stakeholders. And what came out of those meetings was that we added a fourth category for the resources in the Philippines, which was community information. Information aimed at general community members and community health workers, because especially in lower resource healthcare settings, there are not enough licensed healthcare workers to do a lot of this risk reduction work. And a lot of this risk reduction really means you need to understand the person in front of you, their lived circumstances, and what is actionable for them. And that is where For example, community health workers, health promoters can be really, really effective. So I think that is part of the answer, but we also need generators, and those cost money and have to be prioritized. We also need people to have access to safe cooling in their communities. So this is going to be a multidisciplinary, multi-sectoral effort, but it's really important because, as we've talked about already, impacts on pregnancy are not good during heat. And so access to cool, safe spaces, access to good healthcare that works for you when you need it, those are really important. And we have to be ready to do that if we're dealing not only with heat, but perhaps heat a week after a cyclone that has damaged the power grid. So that's a challenge, but I think there's a lot of good work to be done here.
Thank you so much for that comprehensive explanation that kind of brings in all of the levels, the individual patient, the clinic, the community, and the hearing your reflections. It's very clear that the solutions can't just be from one single-sided effort. Thank you so much. I wanted to follow up and ask a question to Dr. Shri, who mentioned that the Garbony cohort was trying to identify the most impactful temperature levels and the pregnancy windows. And so I wanted you to maybe share a little bit about, maybe it's first trimester for fetal neonatal effects, placentation, maybe it's third trimester for preterm birth. But if you could just articulate what you've specifically found that might be places for intervention and what interventions. You mentioned hydration, but just hearing a little more about the temperature and maternal fetal physiology would be fantastic.
Great. Thank you for that. So, this is preliminary evidence. So, we're currently working on both heat and air pollution models. So, you can notice typically stillbirth has a very distinct preliminary or vulnerable window, end of first trimester, early second trimester. That's where typically you're seeing heightened risk. For preterm birth, it's late second trimester, early third trimester. That's where we're starting to notice the peak in risk. And for SGA or low birth weight, it tends to compound and starts manifesting itself much later in pregnancy towards the end if prolonged exposure does exist. Um, that those are the preliminary reads we are getting from our models, and we are in the process of publishing those. So yes, I think those start giving us general leads. Those are the from the vulnerable windows point of view. And what we also noticed is that we typically have centered our reference ranges either to 24 degrees because most of the air conditioners, not most, all of the air conditioners in India are government mandated to be set at 24 degrees. And we sort of use that as a baseline to go with, and then see beyond that baseline how much of a risk per degree we're trying to get. So roughly, you get maybe about 25% to 30% risk at 28 degrees, 29 degrees, and that goes up to two times the risk if you're consistently exposed to maybe around 35 degrees as things get hotter. This is I'm typically talking about mean temperature because temperature itself has got large number of metrics. You have maximum temperature, mean temperature, and then humidity itself complicates things because just like our watches and our phones tell us that it's actually 37 but it feels like 45 or 46. So it is important to factor in both of those metrics when you do these kind of modelings. Now I mentioned hydration because it's something that I'm pursuing as a separate maybe potential question of my own. Is that everyone knows that if it's hot you need to drink water. I mean it's seemingly a no-brainer, right? But how much, when, is there a vulnerable group? Like, for example, let's take preeclampsia. Right? Preeclampsia, we now know that low dose aspirin, if given when identified early, is known to be protective effects. What's an interesting paper that has come, I think, just recently is people who were given low dose aspirin, turns out that their effects from heat were also mitigated by it. It's just come out in JAMA. So, but yeah, because but then again, that was part of a secondary analysis, right? Um, but the whole question of why I take the analogy of aspirin here is that you need to have water or hydration, but how much, what, based on the weight, based on the presentation of the participant, or the patient. Urine specific gravity can be an excellent screening tool to assess baseline dehydration. And then if you have this is also contingent on and this is for field settings where access to ultrasound may not be possible, as just to sort of compound or to add on to what Dr. Caleb was saying. But if you have access to even decent antenatal care and you know that your uterine blood flow parameters are not working, then you know that's a high risk patient and hydration would definitely be beneficial in those regards according to their weight and the temperature outside. So there are specific formulas for that. It sounds simple, but in implementation, there's a lot of background work that needs to be done. But it is the advantage of solutions like hydrations or something even like cool roofs is it is scalable,
Mhm.
which is something for large, which we, because, there is no one shot cure drug that is going to, I mean, if you look at mechanistically, there are, I mean, we are saying that, pollution and heat reduce cervical length, which is and shortening of cervical length tends to precipitate preterm birth. You know that you can give progesterone and other derivatives for that. But is that a scalable solution for everybody? Probably not. Water is far more easier to do so. So we need to, I think, the advantages of such cohorts in HIP India or Garbini or other programs, I'm sure, is to start finding out the intersection where you can maybe link mechanism, we can link causation and link what interventions are scalable in the long run. Especially for the most vulnerable, in like the informal workers or somebody's put it in the Q&A for migrant workers. So I think yeah.
Thank you so much. As you were talking, the solutions of hydration, maybe electrolytes, reminded me of kind of low cost scalable solutions for diarrheal illness. And maybe that's something that could be innovated to kind of be accessible. But we'll hear from you and your research on that in the coming years, I hope. And Dr. Mirai, I was hoping you could contextualize some of the critical impacts of temperature and climate stress that were mentioned, and that you mentioned yourself. So preterm birth, the devastation of stillbirth, which also comes with heavy bleeding and recovery time. So sometimes the neonate will require advanced support. And so if you could just help us understand how all these complications then trickle down to impact the informal workers.
Yeah. Well, the first thing that I'd like to say is that we do have heat action plans because I'm focusing on heat. And happily, I live in the city of Ahmedabad, which was the first in India to develop a heat action plan. But unfortunately, there are gaps. So, if that's okay, I'd like to just focus a little bit on the gaps because that gives us a little bit more of the context. As I said, we have a heat action plan, but it's more kind of temporary emergency heat wave sort of emergency response. But having said that, we do have regular advisories, including for pregnant women, and there are water stations. I was interested to hear Sri speaking about hydration because our city municipal corporation has put, you know, uh, different water stations across the city and some shade and so on, and has been in dialogue with civil society. But there are huge gaps, and one of the systems normally that we have in our city, and well, more broadly in India, but then with different names, we call it Mamta Divas in our city and in our state, is that the nurses come regularly into the neighborhoods and check up, do antenatal care and also take care of kids, immunization, and so on. So, as I mentioned, that's the first thing that stops or is disrupted or becomes irregular. So I think, focusing on solutions more because I think, both Dr. Caleb and Dr. Sri have, laid it out better, all those gaps and and the impact on neonates and so on. Um, I think one of the first things we need to do is much more orientation in our health system about climate related risks, not just heat, but we are also seeing, cloudbursts, we're seeing flooding. And, in the western part of my state of Gujarat, we regularly have cyclones at this time of year. And frankly speaking, there's still a gap in orientation in our public health system, in our primary health centers, in our urban health centers, uh, on this issue. Not even on occupational health. There's a huge research gap and a knowledge gap. We actually did a survey of about 5,000 studies on occupational health, and we found only 37 on informal workers and only 14 on informal women workers, and there was no link at all with climate change. So we have to begin from there. And as Dr. Sri said, it's a multifactorial approach, a holistic approach. We need the evidence. We don't even know. As I said, we're in the middle of collecting data and we are in a study right now. So I don't have that much more to say on what you said. But I think that, I would like to stress that there's this information gap. And I was really interested to hear Dr. Caleb say, about the toolkit. I wish we could have access to that toolkit and see how we could adapt it. Maybe that's one thing that can emerge from this panel. If Philippines can do it, maybe I can begin the discussion in my city of Ahmedabad to see how we can use the toolkit and adapt it. But I think so I've mentioned already the sort of knowledge and research gap, but I'd also like to talk about what we can do as communities, because we work closely shoulder to shoulder with our sisters. We have trained frontline workers for early detection, risk detection, and so on and so forth. But there is this gap that the Mamta Divases, those women checkups and so on, come to a grinding halt at the time of these kind of crises and risk periods. One of the things we've tried to do is to set up what we call SEWA Shakti Kendras, which are centers embedded in the community, urban and rural, where women have access to information, the schemes, the welfare schemes, the services, and more importantly, the frontline workers. We do have ASHAs and Anganwadi workers, local government frontline workers, but our own SEWA frontline workers then quickly, are able to act because they're embedded right there in the community. So it's kind of similar to what Dr. Caleb was saying. I think what's really a big missing link we find is that there's very little consultation with the informal women workers and the pregnant women themselves. And this is what we've been trying to say. There's, people sitting in their offices might say, all well intentioned, no doubt, don't work between 12 and 4. Well, as you just heard, even, they have to work 12 or 4. Otherwise, how are they going to put food on the table? It's as simple as that. So the importance of co-creating solutions where the workers, then the municipal corporation, local public health authorities sit together and work out what's doable. And the money and the resources are there. For informal workers in India, we do have worker welfare boards, which can provide some basic shade or whatsoever, some preventive information like these kind of toolkits in local language, which can quickly go out to people. And also, we need infrastructure and services to support livelihoods. I think the one thing we hear again and again is, what about my work? I remember after the earthquake in Gujarat so many years ago, to my shock, actually, the first thing women asked us was, have you brought work? That was, because work is the lifeline to survival. So I think, that is something that we've been saying to our government. Maybe it's a cash transfer, maybe it's expanding parametric insurance, but not putting the burden of the entire premium on the workers. Childcare, extended hours childcare. So at least one of the risk factors and one of the sort of stressors from women's lives are removed. And I also mentioned much more interaction, which we're beginning to do as a demonstration in some areas of our state with the primary health centers and urban health centers, so that people ask the questions and are more sensitized to risk factors related to climate. And finally, I think what already has been mentioned, but I'd like to stress it, the importance of, if you will, the social determinants, the other aspects of their lives, like housing. If, like my sister Rehat Ben, you live in a 10 by 15, what are the things you can do? We may not be able to provide low-income housing for 1.4 billion people immediately, but there are low-cost things you can do, like painting the roofs white, trying to figure out ways to make their homes more ventilated. Putting tiles, we have something which in India we call kuchi, some of the Indian colleagues would know, which are like little white porcelain pieces which reflect heat on the roofs. So there are things that we can do. So I think I'd like to focus more on that, if that's okay.
Thank you so much for reframing into a solutions conversation. I think that's really fantastic. And on follow up to this, I was hoping that Dr. Caleb can kind of talk a little bit more about the co-creation of the toolkit, whether or not the there was a community-based development, and if you'd want to bring that in. And I want to highlight an audience question to kind of additionally frame your response, Dr. Caleb. And this question is, what inspirations can LMICs draw from developed countries in strengthening their health system to cater better to maternal health? So if you can kind of talk about your toolkit with a little bit of framing from the audience question.
Yes, absolutely. I would actually flip that audience question and say, what can we be learning in our very expensive high income healthcare system from low and middle income countries that are living with heat? I think we may have a lot to learn where I am in Boston. With that said, the development of the resources I was talking about was a long project involving a lot of people. I took over the Harvard part of that from Dr. Ari Bernstein a few years ago. But this included academic researchers at Harvard. It included staff at AmeriCares, which is a humanitarian nonprofit, and it included members of clinics and associated individuals who are dealing with these impacts in a variety of communities at this point around the world. So what that looked like over time included starting with needs assessment. There was a needs assessment survey and also a series of focus groups to understand, what are people seeing? What are the perceived issues around this intersection of primary health care and climate change? That identified a number of concerns ranging from power stability to providing guidance or having easily accessible information that is accessible in a doctor-patient visit. And it also provided some information on how people wanted to receive that, in this case, in sort of simple documents with lots of graphics. A first version of the toolkit was developed that was piloted with a handful of clinics. Feedback was gathered. A larger scale pilot was run in 2023 with 17 or 18 clinics that involved a season of them implementing this in a variety of different ways, and then semi-structured interviews with users of that toolkit or recipients of that information to understand, how was it used, what was working, what was not, what were the barriers to using this. And we then convened a multidisciplinary, multi-stakeholder revisions process that took about 7 months and re-released the toolkit about a year later, incorporating that feedback. So that was the US version that you can see at the link I just dropped in the chat. So lots of input from a wide variety of people, hugely appreciative of all of their efforts and insights. In the Philippines, we again convened stakeholders for needs assessment. So this included input from academic experts, clinicians, but also input from patient representative groups, for example, representing people living with disabilities, who had concerns about, like, how is this information going to be presented? How is this information going to be accessible? It included input from civil society organizations that are focused on sort of adapting to some of the disaster issues that the Philippines faces and some of the disaster risk reduction community. And so, again, convened stakeholder meetings, developed resources that were then iterated on and that have now been deployed. And, I hope to see monitoring and evaluation data from that at some point in the next year or so that can hopefully inform ongoing development. So I think engaging a lot of people with a lot of backgrounds and a mixture of lived experience with the issue, practical experience with the institutions involved, academic expertise, all of those things are needed for this work. And I also do want to say that I think we need to be very open-minded about what the right answers will wind up being. As Mirai alluded to, things that sound good in my air-conditioned office in Boston may not work in practice. And so this is going to need to be very much a bi-directional, ongoing conversation globally. We're now working with collaborators not only in the Philippines, but also in Australia, in the Eastern Mediterranean, including in Cyprus and elsewhere to try and keep developing and expanding these resources and integrating input from a wide variety of settings to see what we learn. And it's been a really fascinating journey.
Thank you so much. I mean, your response was just so inclusive of the local different contexts in which people experience their lives, and then on top of that, climate extremes. I wanted to, as Dr. Mirai was kind of refocusing us towards solutions, one of my questions, which is really both for Dr. Mirai and Dr. Shri, is how can we take, your resources, Caleb, and start modifying those on top of, many of the efforts that are ongoing in a heterogeneous way. And given Dr. Mirai's network and Dr. Shree's research, how can you all as panelists and we all together as a community start kind of filling the gap that Dr. Mirai said? And I was hoping maybe first, Dr. Mirai, if you can respond to this, and then after Dr. Shree, give your thoughts on how, would you be able to do an RCT after a needs assessment within your cohort to show a demonstrated benefit of kind of these responses? And so, Dr. Mirai.
Yeah, thanks, Dr. Shruti. And I was really interested to hear what Dr. Caleb was saying, and I thought that came to my head was maybe we'll import you to help us have a dialogue with the Ahmedabad Municipal Corporation, because it's both the outcome, which is the concrete toolkit, but it's also the process, which you described so well. And I think that's really important, this whole issue of co-creation and marrying all our strengths, and particularly, hearing from those who we want to reach out to and we want to, serve and be beneficial to. So there's definitely maybe some more interactions between the three of us, maybe facilitated by you and by the school would be wonderful. We'd definitely be open to that. I just wanted to mention one quick thing, which I don't know how I forgot, because as you've gathered, this is quite my hobby horse, which is, I mean, the unfairness of the fact that the mass of informal women workers in our country have no access to maternity benefits. Forget about maternity leave. They don't even get anything. And we do have a system of cash transfers in our country. And when some of us, and I'm happy to say that SEWA was part of it, when we crafted the National Food Security Act with the previous government, which is still in force. And as you know, about 800 million people in our country are getting subsidized food grains. One of the things some of us slipped in was that for all pregnant women, for 6 months, 1,000 rupees a month cash transfer should go to the pregnant woman so she can take time off. She can eat better because, she eats whatever's in the family pot. And therefore, as we know that her weight gain is limited and so on. Unfortunately, that has not really been implemented the way, we had envisaged. And it's a law. But we're told we don't have the resources, this and that whatsoever. But anyway, the point is that this is morphed into just a scheme of the government, a program where, up to two pregnancies, if you've had your child immunized and all that, you do get a cash benefit. But it's not like what we had envisaged, which is, all women, pregnant women are women at risk. All Indian women work, both paid and unpaid, and they jolly well should have some cash transfer like this to help them tide over this period in their life. And it's all the more important and relevant in this context of climate related risks.
Thank you. Dr. Shree, any thoughts on how you would integrate a potential toolkit in your research?
Yeah, thank you. For research, and this is where we were just part of this another grant application where I think risk in social circles and risk in epi are differently defined, and it's important to first marry that. Because if you ask a public, it's a typical epidemiologist is going to give you the mathematical formula, is going to say, oh, with this exposure, with this outcome, your risk is X. But if you look at it from a social point of view, and this was a learning for me myself, social risk is different. Social risk is a combination of many contributing factors, which includes infrastructure, livelihood, whether you're in the formal sector, informal sector. And it's first, I think, important to marry those two things. And when you co-create a toolkit, I think that is the first thing we need to, do because even from policy point of view, and whenever you try to, I was part of, some of the research on booster doses and immunity during COVID as well before I transitioned here, is typically policymakers and administrators like some numbers to go with some impact. So there has to be some quant and some quality. And both of those definitions need to somehow, and for that, such wonderful forums do help in contributing and helping to creating such things. So it is quite pertinent that both of those definitions of risk, both of those vulnerabilities are adequately mapped. As far as an RCT or some sort of an intervention goes, I think there are two aspects to it. One is the actual, causality of an intervention working. Hydration in theory sounds fantastic and it's easy, but how do you know how well it is going to work? How well it's going to be accepted? I see a question in the Q&A saying that, oh, if you drink too much of water for informal workers, how are they going to use the restrooms? So, it has to be very targeted. So, like I had told before, if somebody who you can identify through ASHAs and engage them, ASHAs are the community health workers we have here. If we use them and identify people at risk with baseline dehydration, we know physiologically the body will try to preserve water, and the first thing that it does is try to reduce urine output. So maybe in those it can benefit. It may not be a one shoe fit all approach, and we need to be cognizant of that. The other thing I would just sort of agree with Dr. Caleb's point is that many of the climate change research on pregnancy outcome is on high income countries where I would say many of the problems LMIC space don't exist. They don't, I mean, access to healthcare, even something like so simple like, power, continuous power supply, is not in, non almost practically non-existent in high income countries. So we have to be open to all sorts of solutions. I completely agree with Dr. Caleb in that. So I think that would be one of the first step in this approach.
Thank you for these reflections. I wanted to highlight some questions from the Q&A as well. And I would ask any panelist who feels like they have a good answer, please unmute and jump in. But here is one. States like Kerala perform well on maternal health indicators, yet migrant women often remain invisible within climate adaptation planning. How can health systems identify and support pregnant interstate migrant women during extreme heat conditions?
I guess I'll jump in. Um, so one of the things we've been saying to the Ministry of Labor and Employment in India is the importance, for years we've been saying this, importance of identity cards. And that we do have them now. There's a e-shram process and so on and so forth. But many migrant workers don't have these cards. And actually, they're all citizens of India, and even if they weren't, anyone who needs services should get this support. Um, I'm not that much familiar with Kerala, but in my own state, I must say that, there's a slight tendency. I mean, we are a net receiver state of migrant workers from, mainly Eastern and Central India. And there's sort of a tendency to say, well, bring this documentation, that documentation to show you're not getting this benefit or that benefit from your home state. So one of the things we've been trying to do, and I mentioned those Seva Shakti Kendras, is to help the migrant workers when they interact with the public health system, particularly pregnant women, so they get access to all the other kinds of, like Janani Suraksha Yojana that was mentioned, I think, all the different schemes. And that just because they're a migrant worker and, they have to prove that they didn't take a benefit from somewhere else. I mean, we are digitized. There's a lot that we can check up on. So it's not really, I mean, it's more, frankly, it's a mindset issue, is what I'm trying to say. And I think it's organ civil society, unions, cooperatives like ours, which constantly interact, and slowly we see change. And it's not just for pregnant women. I remember in one primary health center in Surat, a net receiver city, um, they complained that, oh, all these migrants from Orissa come and they bring filaria. We've just, dealt with this problem and now we have this problem again, as if, they're pain in the neck. Rather than doing the screening and so on and so forth. So the same sort of attitude prevails for pregnant women in some of the receiver states. But as I said, I'm not that familiar with Kerala.
Thank you. You'd mentioned something that, a lot of things are digitized. And so I was just wondering if maybe, Caleb, if you can comment a little bit, if you know about kind of the penetration of digital tools or cell phones as a potential kind of network for either detecting or responding to heat extremes.
Yeah, great question. There are a lot of opportunities here. I also, at a very basic level, if our concern is physical exposure to heat and the physiologic impacts, or physical exposure to other climate hazards, right? Dengue, cyclones, flooding, we need physical infrastructure to deal with that. So I don't think we can fully solve this with, AI and cell phones. That said, there are some opportunities to do some good. Um, what are some of those? So, one is in the area of sort of early warning, notification, and behavior change. So, if we think about, for example, cyclone warning systems in areas along the Bay of Bengal, knowing that a cyclone is coming, paired with actionable information and infrastructure in some places, elevated cyclone shelters, saves lives, right? And so, if we extend that to other hazards, there may be opportunities for putting out information that is timely and actionable to people through electronic means, including devices. So that's an opportunity. It's also not a guaranteed win. When researchers have looked at data in the United States, it's not clear that sending out warnings that it's going to be hot is actually protective. There have been a lot of null findings in large scale population studies in the United States. I don't know how that translates to India, but it's something that certainly needs to be studied before we assume that it has solved a problem. So that's sort of one area. A second area that is really, really interesting to me is the telemedicine piece of this, where if you think about the act of going to the doctor, you have to go outside, you have to go through the local transportation system, or you have to walk. And for a lot of people, they have to walk. If you're doing that in the heat of the day, that is a health risk. And so, why are we making people do that? Are there other ways to do this? I work in an emergency room. A lot of the care I do is very hands-on, but there's also a lot of healthcare that can be done via telemedicine. And so, building out telemedicine is sort of a triple benefit in this space. It increases accessibility, at least for people who know somebody who has a phone they can use. It reduces carbon emissions if people were going to take local transport and reduces local air pollution. So we're burning less fossil fuels. And if it's a heat wave, it can improve accessibility to healthcare without putting people at risk. So lots of opportunities there in terms of sort of enhancing access in a climate-friendly way. But again, it doesn't fully replace hands-on care. Sometimes you need an ultrasound. Sometimes you need a physical exam. And so I don't think we want to oversell these, but I think we certainly do want to figure out where they're effective and build that out as much as we can.
Thank you. Any reflections on that, Dr. Mirai or Dr. Shri?
Maybe Dr. Shri would like to go.
No, I agree with Caleb
Yeah,
100%. I
I
think we
didn't
have,
have much more to add. Yeah,
yeah.
go ahead.
I heard general agreement, so
Yes,
I'm
yes.
going to bring in another question from our audience. So, how might urban heat islands increase health challenges for women, informal workers, and how could these challenges differ from those faced in rural healthcare settings? Open to any of the panelists.
Well, I thought I spoke to some of them. Of course, some of the urban areas are like mine, are heat islands. But it's not that the issues are that different, frankly. And they're different sets of issues. I mean, I think for rural informal women workers, the biggest issue is access. There's transport, there's access, they may or may not have a phone, um, so on and so forth. Fortunately, in most of our states, they go by different names, but we have 108, which are these emergency ambulances that show up. And in many states, including mine, they work well. But, transport in many places is an issue. And I was just in Bihar where the superintendent of a rural hospital said that, because we don't have enough ambulances, the women who come to us come too late. We're not able to save them. And he was quite distressed about that. So there's those kinds of issues. Those kinds of issues are not there for urban pregnant women, but there are different kinds of issues, including, and someone mentioned that in the question in the chat, the attitude of caregivers is one of them. Many of them are not sensitive to the workers, or they have to wait around, things like that. So all of that is difficult, but I think they're not that different. The issues of urban and rural, they're different because of the geography and location. But having said that, I must say, having been joined as a young public health worker long, long ago, I'm afraid, I do see changes. I do see much improvement in many states, including mine, on maternal health, maternal care, maternal mortality, and so on.
That's a very good trajectory that you've seen improvements. Absolutely. One question that I wanted to ask Dr. Shree, just in follow-up to kind of defining risk and the epidemiologic definition, but then also the social definition, and thinking about the complexities and mixtures that kind of contribute to that risk. So this is the question. It's that given that pregnant women are exposed to multiple overlapping risks, heat, lack of healthy nutrition, infections, how can research better capture this complexity? You were alluding to it a little bit, and I just wanted to hear more so that it can inform integrated interventions.
Right, thank you. So again, if I look at it from an epidemiological epi point of view, it's the easiest one is to calculate attributable fractions. Look at what each particular thing. I mean, that's the most logical way and quantifiable way to do it. But it's like I said, it's not just limited to that. As Dr. Mirai and Dr. Caleb have said, there are infrastructural, public health, social barriers also that prevent and compound this risk, which sometimes can't be quantified. You cannot, I mean, you will know that they exist, but the extent of that, especially in rural areas where access is a big, big problem, so we know, okay, let's say we know that 30 degrees above your risk increases by 1.5 for temperature. In the villages, the option for anyone to, effectively act, let's say even somebody develops preeclampsia or some similar hypertensive disorder, the care is the nearest care might be a little bit far away. So I think the obvious solution there would be to improve transportation and improve local healthcare infrastructure as well as local health support. So it has to be a combination of both those things, and it cannot be just one. It cannot be done in silos. I think one of those things I am also realizing as I am trying to mature in this field is to realize that it has to be hand in hand, not only formal, informal, social, as well as as quantifiable science has to go hand in hand. Otherwise, that is the intersection is of that is actually where you're going to find you know actionable solutions that are going to work. Otherwise, it's just going to be, it may work, but it may not be practical, or it may be practical, but it may not be scalable, or if or it can neither be practical. It may work, but it's going to be very, very isolated or very for a very limited population. So yeah, we need to find that intersection, and I think that's truly the need of the hour right
I just wanted to say I totally agree with Dr. Shri, but one thing I would like to mention in this access issue, particularly in rural areas, is what we haven't spoken about and is perhaps a typical Indian sort of issue is that of caste and also which community you belong to, whether you're from a religious or ethnic minority, linguistic minority. That's what we hear quite a lot as we go across India and look at different differentials in access and basically the issue of inequity and inequality in our country, which I'm sorry to say is looming large and is the gap seems to be increasing rather than coming closer together. So I think, as you were talking, Dr. Shri, I feel that that also has to be factored in. You know, people go late or don't go at all to the caregivers or to the facilities because they don't have faith that they will be treated fairly as an equal citizen of the country. And this is a very difficult and sad situation, but it is the reality. And I think we need to also put it up there, up front.
now. I would just like to add here. So for doctors, at least, I think I happen to do some of my training in Kerala, and then it does have a fantastic public health system, no doubt about it. Um, I think we as healthcare workers also need to be very seriously sensitized about this, and it is for the caste and the community issue. I think the best. I mean, a top-down approach may help more than a bottoms-up one, because the resistance to these cultural and caste identification is more prevalent at the lower level than at when you subsequently go higher in the education chain or in hierarchy. So I think if the major health workers are sensitized and it's regularly driven, and then examples are set in workplace, I think, yeah, I speak from my own experience in that regard, but yeah, there's certainly work needs to be done there. I agree with that.
And also, the frontline workers, in our experience, have to be drawn from these very communities. And then there's the capacity building, and then, slowly, slowly, those barriers. I don't end on a negative note. Slowly, slowly, those barriers go. As the health system realizes and understands that this is win-win. If we work together, we will have access, we'll get early referrals of pregnant women, we'll be able to save lives. But it takes a while. But I think once with properly trained frontline workers, we find that, those barriers, first they didn't dare to even enter the primary health center. Now the doctors here, have a seat, have a cup of tea, that sort of a thing. So we also have to be patient. It's the whole process of social change, isn't it?
These comments, we are close to concluding our amazing conversation right now, but I just wanted to reflect that much of what we just started talking about is really that the health of the community and the health of the individual and the health of the nation are inextricably linked, and not only one nation or one country, but globally as well. And so I just wanted to invite Dr. Dresser to have any concluding reflections in our last few minutes as well.
Yeah, I mean, I think at a very large scale, our goal shared, this will play out differently for different people, but I think at a very large scale, is we need to continue to characterize the problem. What are the impacts of climate change on people, on healthcare systems? We need to understand mechanisms, right? Some of Dr. Sri's work is really essential to this. But we also need to understand some of the social mechanisms that are driving this as well. It needs to be physiology and social together. And then we need to be developing and ultimately scaling solutions. And as we think about how to do that, I think there's going to be a lot of bidirectional flow of information from different countries, from different segments or sectors of society. And as we do that, I think a couple things can be really helpful. Item one, case studies of success. There was a paper published a few years ago looking at what happened to neonatal outcomes by moving the neonatal ward to a cooler part of the hospital in Ahmedabad. Mortality got lower. That's great. That's actionable. We need more case studies like that that provide a fairly clear, here's how you problem solve in this area. Stories of success. And then second, we need to be thinking beyond our little silos into understanding what the decision makers that affect policies or people we are working with actually care about. And we need to provide information and metrics they understand. For some people, that's economic terms. For some people, that's quality metrics. For some of the work I'm doing here in Boston, I've started looking at endpoints in my research that are not traditional public health endpoints, but might be things like quality metrics for my emergency department that just are part of how you run a hospital. And that's what administrators are interested in. So we need to learn one another's language across fields so we can present information to decision makers that feels important and actionable to them.
Thank you so much. This conversation has already concluded. We are at time. I just wanted to thank every one of our panelists, Dr. Caleb, Dr. Mirai, Dr. Shri, for this insightful conversation. I wanted to thank our audience for your attentive listening and questions, and also to the India Research Center to support this series of conversations. Thank you, everyone. Thank you so much.